And it's my pleasure and privilege and honor to introduce Dr. Harbaugh. Many of you know Dr. Harbaugh from the weekend when he took us through the biostatistics course. And Dr. Harbaugh was the past president, is now the past president or former president of the AANS, and was the past president of the Senior Society of Neurosurgeons of America, where the very senior neurosurgeons are in that society. And he's the vice president of the Penn State Medical Center, and he's the official sponsor of this course as well, because it's a Listserv is a group of friends, but the legal entity is Dr. Harbaugh, who's kindly signed all the legal papers. So he has been integral to this course, and it's a real. I met Dr. Harbaugh back in 2005, and our shared passion was unruptured aneurysms. He looked through all my projects, and nice to see where we are now. Thank you very much.
Well, thank you. Thank you for the opportunity. I think this is a great course. Thanks to Naren for all the energy that goes into organizing this, Stryker for giving us these facilities and supporting the course, all the faculty. One observation about Kevin's talk, I mean, I think it points out how important it is for neurosurgeons to be able to do both open and endovascular procedures. You know, if there's a saying in the United States that if all you have is a hammer, everything looks like a nail. If you only have one option, then you're going to try to do things endovascularly that might best be done surgically, and vice versa. If all you can do is surgery, you may be inclined to do things surgically that should be done endovascularly. And by being able to do both, I think you can look at the individual patient and try and choose the best option. So going forward, I think neurosurgeons being trained to do both endovascular and open surgery for the treatment of cerebrovascular disease is important. Naren asked me to talk today about the management of unruptured intracranial aneurysms. So I'm going to start out with my disclosure slide. It shows I'm adequately bought and paid for, but none of these things represent a conflict of interest with the talk I'll give today. So let me give you a case report. This is a patient who came in a few years ago, seen in clinic on February 8th. It was a healthy 74-year-old woman with a long history of headaches. It had migraines for decades. And somebody had decided to get an MRI scan. The MRI scan showed a right frontal cavernous angioma, but this was read by an outside radiologist as a vascular malformation. So that patient's local neurologist said, well, we ought to get an angiogram because she has a vascular malformation. So they got an angiogram, which of course showed nothing because a cavernous angioma is angiographically occult. But it did show this tiny little, oops, sorry. This tiny little aneurysm right here, anterior cerebral aneurysm. So I talked to this lady and I said, you know, 74 years old, the risk of rupture of that aneurysm is a fraction of 1% per year. There's no treatment that we offer, endovascular or open, that's as safe as the natural history. And so I reassured her that by far the best thing to do was just to quit worrying about this. If it made her feel better, we could do an imaging study in a year, but it's unlikely that anything other than angiography would pick this up. I was very optimistic with her. She didn't need to worry about this. Well, I next saw this patient less than a month later, March 4th. She had driven her car off the road, and she was found in the car obtunded by the local emergency medicine technicians. They took her to her local hospital, and this was her CT scan. And of course, that tiny little aneurysm had gone on to rupture. And so now she's in our emergency room, and after having told the family that they really didn't need to worry about this, and this is such a small aneurysm, you shouldn't be concerned. Less than a month later, she's back in with a subarachnoid hemorrhage. And that trip to the emergency room to talk to the family about, well, all those things I told you less than a month ago, well, never mind. That's not true. And so one of the things in neurosurgery, you'll have many days when you feel like the only purpose of your life is to serve as a warning to others. And that's how I felt on that day. So I had to talk to the family and say, well, even though the risk of rupture of that aneurysm was very low, it did rupture, so now we need to go ahead and treat it. So she went on to have surgery, did fine, thankfully. But I think this points out the problem we have, that we need to try and figure out who to treat in someone who has an unruptured aneurysm. You know that we're finding more and more aneurysms incidentally. If you look at imaging studies, somewhere between 0.5 and 2% of the population probably harbor an intracranial aneurysm, found often incidentally in these studies. If you look at autopsy studies, depending on what you count as an aneurysm, the incidence of aneurysm ranges anywhere from 1 to 9% of the population harboring an intracranial aneurysm. And most of these are asymptomatic and may remain asymptomatic. So you don't want to put people through invasive treatment if they have a anatomical abnormality that's not going to cause them any problems. However, as Kevin pointed out, if the aneurysm goes on to rupture, there's a 30 to 50% 1-month mortality. And so it's not like the meningioma, where you can say, okay, we found an incidental meningioma, we'll just follow it. It's not going to do anything dramatic. It may get bigger, at which point we can treat it. There's a nice approach to that allows you plenty of time to think and consider and see how this lesion's going to behave. The problem with the aneurysm is the first symptom is often the last symptom because it has such a bad natural history after rupture. And then, of course, all of our aneurysm treatments have some morbidity and mortality, whether it's surgical or endovascular. And so how do we determine which unruptured intracranial aneurysms to treat? Well, a lot of people have put a lot of effort into trying to figure that out. And we do know that there are some very clear risk factors. Size is one. Larger unruptured aneurysms have a greater risk of rupture. Here are some of the investigators that have been involved with this, with the ISUIA studies being probably the best known. We know that an aneurysm that shows enlargement over time has a greater risk of subsequent rupture. So often we'll do surveillance imaging. So you see the aneurysm is changing, getting larger, changing in shape, that's a risk factor, and then those patients go on to be treated. We know that patients who have had a previous subarachnoid hemorrhage from another aneurysm have a higher risk of rupture in their unruptured aneurysms. Location, posterior circulation aneurysms appear to be more hazardous, intracavernous aneurysms less risky. And then there are a number of patient-related factors. Age, females are more likely to have subarachnoid hemorrhage. There are comorbidities that are associated with aneurysm formation and rupture, like cigarette smoking. And then morphology is also important. The aneurysm shape, the relationship of the aneurysm to the parent vessel. And much of my research over the last 20 years has been done with bioengineer Madhavan Raghavan, looking at aneurysm shape and risk of rupture. So we know a lot about things that change the risk of rupture, but it's still controversial as to which patient should be treated. So let's just go over some of the data we do have. As I said, the International Study of Unruptured Intracranial Aneurysms is probably the best known. This, when it says combined cohort, their initial study looked at retrospective data. They asked the participating centers to review the records, plus prospective data that they gathered. And if you look at the effect of size on risk of rupture, if you had compared to the small aneurysms, a 7 to 9 millimeter aneurysm was twice as likely to rupture. 10 to 15 millimeters, 6 times as likely to rupture. 16 to 24, 10 times as likely. And then 25 plus, almost 30 times as likely. So it was very clear that as the aneurysm got bigger, the annual risk of rupture went up. So that was actually one of the biggest findings out of the ISUIA study. The controversial finding, though, was that the small aneurysms seemed to be very, very safe, and we'll talk more about that in a second. If you look at just the prospective part of the ISUIA study, and in their prospective data, they divided it into 2 groups. Group 1 are patients who had truly incidental aneurysms, had never had a subarachnoid hemorrhage. Group 2 were patients who had had a previous subarachnoid hemorrhage, had 1 aneurysm treated, but were found to have an unruptured intracranial aneurysm as well. And what was found was that there were some differences. So, for instance, in the small aneurysms, in the patients who had had another aneurysm rupture, had not had another aneurysm rupture, the risk of rupture in this size was almost 0, 1 per 1,000 aneurysms per year. 5 times higher, although still fairly low, in the people who had a previous subarachnoid. In this size range, and no previous subarachnoid hemorrhage. In the first year after discovery, there was about a 7% risk of rupture, but then it dropped off to 1% per year, suggesting that there may have been something about the aneurysm, it had grown suddenly, did something happen that led to its diagnosis, and so that in that short time period, the risk was higher, but then leveled off. Didn't see that in the people who were followed because they'd had a previous subarachnoid hemorrhage. And then in the 25 plus percent, again, 17% in the first year after diagnosis in this group, and then that group dropped off too to about 2% per year. And there were really no patients that fell into that category in the previous subarachnoid hemorrhage group. So here's some of the concerns about this. If you look at the ISUIA data, if you look at systematic reviews of this topic, aneurysm size and rupture risk, you look at pooled analyses of various series, selected short-term cohort studies, and they have all concluded that small unruptured intracranial aneurysms have a very low annual risk of rupture. I mean, that data is pretty compelling. But then you step back for a second and you say, okay, if small unruptured intracranial aneurysms don't bleed, why are most ruptured aneurysms small? There's a real disconnect there, and it causes people a lot of cognitive dissonance trying to explain this. 85 to 90% of ruptured aneurysms are less than 10 millimeters. So we're told that, aneurysms less than 10 millimeters in size, the initial ISUIA recommendation, you shouldn't treat because they don't rupture. But then you find that, the vast majority of ruptured aneurysms are actually less than 10 millimeters. There's something wrong there. 70 to 80% of ruptured aneurysms, are less than 7 millimeters, 50% less than 5 millimeters. So there's some real disconnect here in regard to size and rupture risk. And people have really struggled to try to explain that. So one of the ways that has come up is to say, well, let's look at the ISUIA study. What did they really do? You know, ISUIA, because it was international and multi-center and published in good journals, got a lot of credence, but it's not anything like gold standard evidence. So remember how it was done. In ISUIA, all the patients were evaluated by cerebrovascular specialists. In some, treatment was recommended, endovascular or open treatment, but in others, surveillance imaging was recommended. You know, why? Well, I think the obvious answer is the cerebrovascular specialists who saw these patients, if they thought the aneurysm had a high risk of rupture, would recommend treatment to prevent the rupture. If they thought the aneurysm was safe, they said, well, you know, the risk of treatment is going to outweigh the risk of the natural history. Let's just watch it. So it's not randomized. People are looking at all kinds of factors to determine which patients they recommend treatment for and which patients they recommend observation. And so the question is, do these two groups have the same natural history? I would say almost certainly not, unless we know nothing, unless we're just blindly picking aneurysms to treat and others to observe. I would hope these two groups have a different natural history. And I think the most parsimonious explanation of the ISUIA data is that you know, the people who evaluated these patients maybe actually did a pretty good job of picking out those patients at high risk who then went on to have treatment, and so that the patients in whom observation was recommended had a low risk of rupture because the people who evaluated them said, I think this group of patients will have a low risk of rupture. The other thing about ISUIA is in many the aneurysms that were initially chosen for observation, you know, they continued to have surveillance, and if the surveillance imaging showed a change in aneurysm size or shape, they went on to treatment before they had a subarachnoid hemorrhage. So you would expect that initial observation group to have a low risk of hemorrhage. And, you know, the ISUIA study really tells us nothing about the natural history of those aneurysms that were chosen for treatment. We don't know how they would have behaved had treatment not been done. So if small unruptured intracranial aneurysms don't bleed, why are most unruptured aneurysms small? Well, yeah, people have tried different ways of explaining this. Actually, Kevin and I were both at a recent FDA, federal agency in the United States meeting where you know, the topic was how can we decide which unruptured intracranial aneurysms require treatment. And one of the people on that panel said, well, you know, if the vast majority of unruptured aneurysms are very small, so even with a low rate of hemorrhage, you'll still see the majority of hemorrhages occurring in small aneurysms. You know, if it makes sense. If, you know, 90+% of the unruptured aneurysms are small, you know, you'll see most of the ruptures in that group. There's some pretty good data to say that's really not the case. Because if you look at studies that looked at the size distribution of both ruptured and unruptured aneurysms, there doesn't seem to be a lot of difference. So here's you know, a review. If you look at the studies of ruptured intracranial aneurysms, ISAT and some others, less than 5 millimeters, it's about 50%. If you look at the ISUIA study for unruptured aneurysms, it's about 50%. Less than 10 millimeters, but bigger than 5. I mean, less than 10 millimeters, 85 to 90%, 74%. Greater than 10 millimeters. So it really doesn't seem like the vast majority of unruptured intracranial aneurysms are tiny, and that's why we see them overrepresented in the ruptured group. So I think we can rule out that explanation. Here's an interesting one, and this has gotten a lot of credence. This says, well, aneurysms may grow very quickly and then rupture at a small size. So that's the ones we see come in, the small aneurysms with subarachnoid hemorrhage. Or they can grow more slowly and stabilize at a small size. And that's the ones that we pick up as unruptured intracranial aneurysms, and we follow them and they don't bleed. Or they can continue to grow and then they become large or giant aneurysms and may eventually go on to rupture. It's a very non-scientific explanation, because you can never, really test this. Essentially what they're saying is that, if you find a small aneurysm that's unruptured, well, you really don't need to worry about it, because somehow just finding it means it's one of these stable aneurysms you don't have to worry about. Whereas the ones that come in with the subarachnoid hemorrhage were the ones that grew quickly. But there's no way to really determine that, because at the time of diagnosis, you have no idea if that aneurysm is stable or growing. You don't know, you can't predict what that aneurysm is going to do. We know that larger aneurysms in smokers are more likely to grow, and they're also more likely to rupture. So there is this association between growth and rupture. But it doesn't help us when we find a patient with an unruptured small aneurysm. There are a lot of other differences in characteristics, aneurysm characteristics, between the ruptured and unruptured groups. There's a study in stroke, 2014, that I thought was very interesting, and it looked at these characteristics. It turns out that the largest aneurysm intracranially had not ruptured in about a third of these 124 patients. So a patient presents with subarachnoid hemorrhage from an aneurysm rupture. They have multiple aneurysms. A third of the time, the biggest aneurysm wasn't the one that ruptured. They looked at things like the aspect ratio, the ratio of the neck to the height of the aneurysm. If the height to neck ratio is greater than 1.3, there is a 3.3 times risk of rupture. In irregular shape, which is what we've been studying for a long time, there was a 3-time increased risk of rupture. And those were after adjustment for aneurysm size and location. So I think what we're getting to is we're starting to appreciate, aneurysm size is one of the things you worry about in regarding risk of rupture. Aneurysm location and aneurysm shape are other things. Some medical comorbidities are to be considered. So let's look at the ISUIA data in regard to location. Cavernous aneurysms, no surprise, have a relatively low risk of rupture, relative risk of 0.2 compared to the universal data set. Middle cerebral aneurysms, 2.2. Posterior communicating aneurysms, 3.2 times as likely as the whole aneurysm cohort. Vertebro-basilar, 2.8. Basilar apex, almost 4 times as likely. So it seems very clear that in addition to aneurysm size, aneurysm location is important. If you go back to that original case presentation I gave you, I think one of the things that I should have considered is that the ratio of the aneurysm size to the size of the parent vessel. So that small aneurysm in that lady coming off a distal anterior cerebral vessel had a significantly higher risk of rupture than an aneurysm of the same size had that come off the internal carotid artery. So again, it's more than just measuring the aneurysm and deciding what the risk of rupture is. Location is going to be important. If you look at population-based studies, there are some risk factors. This is from studies in Finland and Norway. Saw that things like female sex, cigarette smoking, hypertension really had a pretty profound effect on the risk of subarachnoid hemorrhage. these studies showed 3 risk factors: smoking, sex, and blood pressure. One of my residents said, so what that says is that if you don't smoke, you don't have sex, and you have no blood pressure, you won't have a subarachnoid hemorrhage. Now, I think that's probably true, but the real interpretation was that if you looked at the incidence of subarachnoid hemorrhage among women who smoked and had a systolic blood pressure of 160 or higher, it was 20 times higher than in men who had never smoked and had well-controlled or low blood pressure. So those sorts of, patient-specific factors have a real effect on the incidence of subarachnoid hemorrhage. So here we are. 2018, we've been arguing about this for a long time. ISUIA came out decades ago. How do we get more data? And what we're really trying to figure out, and this goes back to what Kevin was talking about with the ruptured aneurysms, what's the best option for this particular patient with this particular aneurysm? And I think that we could get much better answers, and I'm going to suggest a way of doing that. So one good way to start is let's do a decision analysis, formal decision analysis, taking some data that are available in the literature. And that's not going to tell us what to do, but it's really going to help to clarify what the issues are and how we need to approach next steps. After we do the decision analysis, then we're going to look at some options for gathering further data, randomized trial or a registry approach. So this is a decision analysis we did, and we said we're going to take a cohort of patients. These patients are 40 years old. They start out neurologically well. We're going to use the natural history rupture rate from ISUIA. This is all sizes of aneurysm. So we're going to say the natural history rupture rate is 1.46%. We're going to use the clipping and coiling morbidity data from the ISUIA studies. So we're going to say clipping has an 11% morbidity and mortality, but it's going to decrease the risk of future hemorrhage by 95%. I don't know if that's right. It may well be that clipping and coiling reduce the risk of future hemorrhage by the same percent, but this is part of our model, so you have to be clear about how the model is constructed. Coiling has half the upfront morbidity and mortality and decreases the risk of hemorrhage by 75%. Again, I don't know if that's right, but that's our model. And this is just to clarify the issues we need to consider. And then we can take the annual actuarial risks of death from all causes from U.S. health statistics. You do a standard discount rate for later years of life. And then you run this through your program, and you assign quality adjusted life years via what's called a Monte Carlo method for different outcomes based on this data. And if you do this, here's what this model generates. At 1 year from entry into the study, if you said what's the best option for treating these 40-year-olds with unruptured intracranial aneurysms, observation is the big winner. Because remember, there's only a 1.46% risk of rupture. Both clipping and coiling have upfront morbidity. So at 1 year into the cycle, observation gives you the most quality adjusted life years. Keep running the cycle. 5 years from entry into the study, now coiling has become your best option. Why? Well, coiling has a low upfront morbidity. It's 75% effective in this model at preventing subsequent aneurysm rupture. And so there's been enough aneurysmal subarachnoid hemorrhage with very bad outcomes, as we know, in the observation group, so that this low upfront morbidity, the natural history morbidity is past the coiling morbidity. Clipping is now moved into second place, and at 5 years, observation is the worst option. If you run it through the lifetime of the patient, actually clipping moves into first place because of its greater effectiveness at preventing subsequent subarachnoid hemorrhage. But this is our model, and that may not be true. If coiling and clipping have the same subsequent risk of hemorrhage, then clipping is always going to be secondary to coiling because it has a lower upfront morbidity. But the important point about this, I think, is to really know what's the best option for that whole cohort, you need very long-term studies. And the crossover point for clipping versus coiling in our model was 10.5 years. So, which means you'd probably have to, if you're doing a randomized study, you'd have to run it out maybe 15 years to find this kind of result. And the value of a decision analysis is not to give you the right answer, it's to clarify the issues. So here's some of the things to think about if we want to gather more data. The randomized controlled trial is considered a gold standard, but there are lots of problems with randomized controlled trials in surgery. We have the problem with intention to treat and crossovers. Kevin mentioned that in the BRAT trial. The surgeons who participate in randomized trials, the patients in the randomized trials really may not be representative, and we know that surgical expertise or endovascular expertise is going to have a really profound effect on study outcome. That's an important variable. RCTs, they tend to be very expensive and labor intensive, and nobody does 15-year randomized trials. And then as technology changes, the results from an RCT may be invalidated. I think what we've seen in a very short period of time, the last 10 years certainly, the endovascular options for treating aneurysms have changed very, very rapidly, and we need some method that accounts for that. But the biggest problem with an RCT in unruptured aneurysms is lack of equipoise among the treating surgeons. There was a proposal submitted to the National Institutes of Health in the United States a number of years ago now, trying to do a randomized trial of unruptured intracranial aneurysms. It was put in by the ISUIA investigators. I was asked to review that, and I think it would have given us very bad data for the following reason. Let's take a couple of cases. You're in clinic, and you see a 40-year-old woman. She has a positive family history of aneurysm rupture. She's a cigarette smoker, and she has a 10-millimeter irregularly shaped basilar apex aneurysm. By all we know about the natural history of aneurysms, this is a patient at very high risk of rupture. And I've asked a number of my vascular neurosurgery colleagues how many people would be willing to randomize that patient to a trial that included clipping, coiling, and observation. And so far, only one person was willing to do that. Next patient who comes in is a 65-year-old woman, no family history of aneurysm rupture, non-smoker, 7-millimeter, very regularly shaped ophthalmic artery aneurysm. Most of the people I've talked to said they would be willing to randomize that patient. Now, why? Well, you don't want to randomize the first one because you're convinced that she should be treated, and so you say, look, we have this study, but this aneurysm really needs to be coiled. So let's go get this aneurysm taken care of. We'll do this outside the trial. Why? Because we thought her risk of rupture was high. The next one is saying, well, by all we know about aneurysms, the risk of rupture in this patient's probably pretty low. Actually, this patient in my clinic would be assigned to surveillance imaging. But if we had a randomized trial, you'd say, well, okay, let's go ahead and put her in the trial. Now look what we've done. We've taken the patient at high risk of rupture, and we've treated that patient outside the trial. We take the patients at low risk of rupture, and we say, we'll randomize. So you randomize these patients. I would bet almost anything that we find that at least in a relatively short period of time, 1 to 5 years, that observation is going to be your best option because the natural history risk is so low. But if that gets published, now that becomes level 1 evidence. Now you can't operate on the first person. You can't treat her because there's literature that says the best treatment for unruptured intracranial aneurysms is observation. This would be, I think, a very dangerous study. And then the question is, how long do you run such a study? 2 years? 5 years? 15 years? My bet is, from our decision analysis, you get very different answers at 2, 5, and 15 years. And this study was proposed for a follow-up point, an endpoint at 1 year after randomization. I mean, and my assessment of that is, why bother to do this study? We know it's going to be observation, save the money. There really isn't equipoise here, so I don't think that that's a good option to try to do an RCT. So could we do a registry approach? And this is where I think we have a great opportunity to do this. If you think about it, a good randomized controlled trial differs from a good observational study in only one design element, and that's the use of randomization to allocate patients to treatment groups. Why do you randomize? The only reason that randomization makes a difference is confounders. So you say we're going to randomize to one group or the other, so we equally distribute the confounding aspects of the patients. And then if that randomization is done and the confounders are equally distributed, we can compare treatment effects directly within the trial. But as we've seen, if you take patients out of the trial ahead of time, you don't get rid of the confounders. You just say, well, all of those confounding effects, cigarette smoking, aneurysm size, aneurysm shape, location, sex, we're just going to take all of those out and treat the people we think are at high risk. So you don't actually distribute the confounders equally because of your patient selection. Now, in an observational study, when you do a registry, treatment selection is obviously influenced by these covariants. And so you need to be able to address those in your registry so that you can compare treatment effects. But there are ways to do that. We do it retrospectively very commonly with things like multivariable analysis. But I think a better option is propensity score matching. And the propensity score is simply the probability of treatment assignment due to these baseline covariates. So, the younger patient, the female patient, the patient with a posterior circulation aneurysm, the patient who smokes, the patient with an irregular aneurysm are much more likely to get assigned to treatment than to observation. Those are the things that cerebrovascular specialists consider when they decide who to treat. So we need to address those. We need to collect that data in our registry. Patients with the same propensity score have the same distribution of these covariates, but differ only in regard to intervention. So if you could get two groups of patients who have the same propensity score for the variables we're going to talk about in a second, differ in regard to observation, clipping, or coiling, now you can actually draw causal inferences. You can compare those groups the same way you would in a randomized trial. So propensity score matching is a way to do sort of pseudo randomization, if you would. So let's just look at the trial design components. In a well-designed surgical RCT, are the results masked? Almost never. You hardly ever see a double-blind surgical trial. Is it prospective? Yes. Is it randomized? Yes, it's an RCT. And is it generalizable? Well, probably not, because as I think we've talked about, the lack of equipoise, highly selected patients, highly selected surgeons means that the results within the randomized trial may not apply to the whole population of surgeons and patients. Well, how about a retrospective database? Well, that's pretty much useless because it's not masked, it's not prospective, there's no randomization, and a lot of times you see these registries published as advertising. Look how good I did. So I don't put much credence in that. A prospective registry, not masked. It is prospective. It's not randomized. It is generalizable in the sense that if you have a good prospective registry, it shows what the outcomes really are in the community, as these patients are evaluated and treated. But if you add the propensity score matching piece, the thing you get is this pseudo randomization. So, that is going to help you with the confounding variables. I think it's really a good option for something like this. So, if you want to design a registry to do propensity score matching, there are a series of steps to go through. And remember, the propensity score is, about treatment assignment. So you say, what randomized experiment do we want to model? Who are the decision makers for treatment assignment? What are the key covariates that they use to assign treatment? Can we measure those key covariates? Well, what clinically meaningful outcomes will we measure? And then what sample size will be needed? If we can address all those questions, we can do a good study and can draw causal inferences from a non-randomized trial. So I think for unruptured intracranial aneurysms, it's pretty straightforward. So the randomized experiment we want to model is observation versus invasive treatment, clipping or coiling, for unruptured intracranial aneurysms. Who are the decision makers? It's the physicians, the patients, and the family members. What key covariates are used to decide treatment assignment? It's patient-specific factors like patient age, prior aneurysm rupture, comorbidities, social history, et cetera, et cetera. There are aneurysm-specific factors that we've talked about: aneurysm size, shape, and location, aspect ratio, size of the vessel of origin, the angle between the aneurysm takeoff and the vessel of origin, all kinds of things we could put in here. And then there are physician-specific factors we need to look at. Is this person an endovascular specialist, an open surgical specialist? Can do both, can do neither? How many years of experience? What's the practice setting? All of those things may affect treatment assignment. So to do a propensity score match, we need to look at that data. Can we measure these covariates well? I think in almost every case we can. Clinically meaningful outcomes are pretty straightforward. Certainly look at things like mortality and aneurysm rupture, but I think the really important one is functional health status and quality of life for these patients. And we can calculate the sample size with traditional power calculations. And I think there's no reason this study can't be done except for the lack of funding. So, in summary, I think, right now it remains controversial as to which unruptured intracranial aneurysms should be chosen for treatment. I think there are ways to gather much better data going forward that will probably occur sometime in the foreseeable future. But right now, I think the best option for a patient with an unruptured intracranial aneurysm is to get to a practitioner who can do both endovascular and open surgical treatment, so they have all of the options available to them for treatment, and who have a really deep understanding of those factors that go into affecting the natural history rupture risk of an unruptured intracranial aneurysm, and you're likely to get the best decision for that group of patients. Thank you for the opportunity, and happy to take any questions.
Sarah Taha from Queen Square, London. Thank you very much. This is not a question, it's just a comment. So when we discuss patients in the multidisciplinary team meetings, are we not mimicking this propensity analysis model?
Well, yes. I mean, I think that's exactly what we do. Remember, the propensity score is, the determining treatment assignment. So, what propensity score matching does in a registry is to say, what kind of factors do we take into consideration when we decide if we're going to treat this patient surgically, treat this patient endovascularly, or observe this patient? The problem there is, I mean, that's how we do assign treatment, but we're not sure that that is really right in regard to outcome. So the propensity score adjusted registry says we're going to take all of those factors into consideration. Now, in many aneurysms, we'll find people who have the same propensity score, but for whatever reason at this institution, they have a decision made to go to endovascular treatment. Here they go to surgery. Here they have observation. As we run that registry out, we can now compare those propensity score match groups and say, well, we thought observation was the best thing at our institution, we thought observation was the best. But this registry data suggests coiling may be a better option. So that's how you do the comparison. It's just as though you had done a randomized trial of all patients, but instead it's pseudo-randomized. The other thing a propensity score match registry would do is it would tell you for which patients there is no equipoise. I mean, for instance, if we did a registry like this, let's say we did it at 30 institutions, my bet is we would find very few patients in that young, female, basilar apex, fairly large, irregular aneurysm group that anybody recommended observation for. I think almost everyone would recommend endovascular treatment at this point. And if that's the case, then that tells you that there is no equipoise. You know, the trialists will say, well, equipoise is determined by the literature. If you don't have level 1 evidence to pick one treatment or another, then equipoise exists. But that's really kind of silly, because where equipoise is really important is at the point where the physician is talking to the patient. And so if you find cohorts of patients like that young woman in my example, where everybody is recommending the same treatment, you know, even if you did a randomized study, you'd never get people to randomize that person. So a propensity score matched registry will tell you those patients for whom equipoise does not exist. But for the vast majority of these patients, I think you will find that there is an ability to do propensity score matching, and then you can look at outcomes based on which treatment they were assigned. Does that make sense?
Questions for Dr. Harbaugh?
Yes, sir.
It is difficult to make a decision on what to do with unruptured, and naturally we tend to turn to scores, right? You know, there's the IZUA, and then there's the UCAS in Japanese, and they have phases, right? What is your take on all of these, and how should we apply them in clinical practice?
Well, again, I think the problem with all of the studies that you mentioned is that, you know, we asked the cerebrovascular specialist to evaluate the patients. If the cerebrovascular specialist looks at the patient, looks at the aneurysm, looks at all these factors that we all consider when we talk to patients, and say, okay, for this particular person, I think that treatment is indicated. So personally, I see a younger patient, smoker, aneurysm irregularity, larger size, relationship of the size of the aneurysm to the size of the parent vessel. All of these things go in the mix. You know, family history, social history, and you know the psychological effect on the patient. I've had some patients where I've recommended that observation is the best choice, and they'll say, I just wake up every morning worried about the aneurysm rupture. I go to bed every night worrying about aneurysm rupture. It's ruining my life. In that case, I mean, I think that's a significant piece of information to say, well, let's get it fixed so you can get on with your life. But the point is, if you have cerebrovascular specialists who do that and then pull a group of patients out for treatment, those patients get pulled out for treatment because we say we think they're at a higher risk of rupture. The patients that are left are going to have a low risk of rupture. And the mistake in ISUIA was they analyzed all of these patients who didn't get treated, and they found they had a low risk of rupture. And then the recommendation was you shouldn't treat patients with aneurysms less than a certain size, because that was the one factor that they had focused on in their analysis. Well, I'm sorry, you know, you know nothing about what would have happened to the patients who got treated, what the natural history of that group of aneurysms was, because they were treated. So, you know, and I suspect the natural history would have been a good deal different than the untreated ones. So I think what ISUIA and these other studies do is they point out some factors in unruptured aneurysms that are probably important for their natural history, but what they don't do is allow you to say aneurysms of less than such and such a size or aneurysms in such and such a location should or shouldn't be treated. Does that make sense? Right. It almost certainly isn't. Right. Right. Yeah. So I mean, I think you raise a very good point. So you have a very complex situation. Any patient has just multiple differences in characteristics. And what we try to do is integrate all of those. We say, for this particular patient with this particular aneurysm, based on everything we know, I think this is the best option. And then with any of the scales, what they do is they try to abstract parts of the data. And, you know, I think ISUIA is the worst, because basically they just say, well, let's look at size and location. But again, it doesn't tell you about, you know, what would have happened to the aneurysms where treatment was recommended. So I don't use any particular scoring method, because I don't think any particular scoring method is very accurate. And really each patient is a different decision based on lots of different factors. What a propensity score match registry would do is allow us to interrogate all of those different factors. And so you could, if you did this long enough with enough centers, I mean, literally say aneurysms between this size and this location with this shape, and patients with these comorbidities. I mean, have a whole list of factors and say, all right, we have 3 cohorts now that we've collected in the registry where all of these things seem to match. These are very well matched patients. This group had observation, this group had endovascular treatment, this group had surgery. What were their outcomes at 1 year, 5 years, 10 years? I mean, it's easier to continue a registry like that than it is a randomized trial. Then I think we start to really get data we can use. And the value of a registry is it's iterative. As it goes on, it becomes more and more powerful because you keep adding patients and you keep adding detail. Before we had the kind of, you know, processing power and storage capabilities that we have now, we couldn't do this. But I think honestly, this is what we're going to see going forward, are these big multi-center registries with propensity score matching that allow us to really draw some causal inferences from that data.
The trauma initiative, the trauma global initiative, where there's the multi-center TBI and stuff.
Correct.
So you're heading towards that direction, maybe.
Right. Like the multi-center traumatic brain injury initiative is exactly the same model. They're saying we can't do randomized studies for that. Let's really get a good registry and see what data we can get from that. I think it's the right approach.
Before we break for coffee, do we have any consensus on MCA aneurysm, whether coiling or clipping is better yet?
No, I don't think so. Again, so the if you have an MCA aneurysm, ruptured or unruptured, I think, again, each patient is a different decision. And to say all MCA aneurysms should be clipped, or all basilar aneurysms should be coiled, or all of anything should be done anyway, is probably not justifiable. Now, there are going to be situations where the overwhelming, I think most basilar aneurysms now, basilar apex aneurysms now, at least in the United States, are going to get coiled. There are fewer and fewer people who've done any number of clippings, and the coiling gets better and better. And I think the morbidity in that case is, clearly different between the surgical and endovascular. So we're going to find things that evolve over time where almost all get done one way or the other. But, I can think of middle cerebral artery aneurysms where you could do either, and, it's really a discussion as to which is better. But I don't think there should be a hard and fast, all of these should be treated one way, all of those should be treated another.
Thank you very much, Dr. Harbaugh. That's fantastic.